Hello everybody, my name is Julie Maddern and I'm the Clinical Director of the Scottish Centre for Simulation and Clinical Human Factors.
Hi Danielle, my name's Andrew, I'm one of the doctors looking after you. Can I ask you a couple of quick questions, is that okay?
My name's Laura Welsh. I am a senior radiographer at Forth Valley Royal Hospital, and I've been working here for about 7 years. So before I started my simulation journey, as far as I was aware, simulation was used for the big things, the major incidents and the cardiac arrests, and I think that was a widely accepted view within the whole department. But when Amrita and Madeline came to the department to introduce themselves, they opened the idea that simulation could be so much more than that. It was for the smaller things to be able to develop on practices that you thought were okay, but you didn't realise how much they could be tweaked to improve the patient journey. So when I first started, I was a bit self-conscious about it all, and I thought, does simulation mean as much to everybody else as what it means to other people in the team? And there's been a mixed response. A lot of the newer team members have come from university and they've been doing simulation at university, so they've got a little taster, whereas a lot of the more established staff, when they first started doing sim 20 years ago, they didn't feel it tailored to the radiography department. So by being able to do the simulation sessions in one of our rooms, it's really kind of brought everybody on board to how simulation can actually work for them. And as I say, it's been smaller tasks that we've been working on, like an unwell patient. We're not nurses. So if a patient becomes unwell, we're not 100% certain on the best course of action, because we don't want to be the last person in a medical setting that's looked at that patient and sent them home. So we created a scenario about a hypoglycemic patient, and now people in our department know where to go to get help. They know that there's a blood glucose box in the department, and a lot of them are now blood glucose trained. So it's, that one scenario has brought out a lot more staff involvement and increased the confidence in unwell patients.
So, how do we lift the chest? Where's the chest there, Danielle, if that's okay? Perfect.
I'm Julie McKinnon. I'm the team manager for Falkirk Council Home Care and the Reablement Service. Personally, it's afforded me the ability to be able to improve practice across all our staff. So we've involved simulation in most of our training. I think it first started out during COVID, and we were looking for innovative ways to ensure that care staff were donning and doffing their PPE properly, and we used it for that. We then also used it for with our pharmacy technicians when they were doing their medication training, in order to allow care staff to have that element of practice before they were actually having to go out and administer medication in people's homes. On a personal note, all through this, my dad had taken extremely ill. He suffered a series of strokes last year, and it's changed my mindset to the point where my dad was paralysed entirely down the left-hand side. But using the simulation, I saw how much care staff appreciated changing the way in which they communicate with service users, and I did the same, taking a much more encouraging approach. And it's given me that ability to be able to support my dad, because he couldn't get a care package at the time. And my dad went from being entirely paralysed down the left-hand side to he's back driving his car. He managed to get himself back to work. And it was through that simulation of building appropriate outcomes for people. And with the simulation, we dealt with communication skills, so it improved care staff's communication skills. You know how you speak to a person in a more encouraging way. And I think because they had that opportunity to all come together and all learn from each other, it's been invaluable for our review.